Thank you all for joining us on today's webinar. Today's topic is on bone marrow transplant in sickle cell disease. I am Dr. Dela Ziga, Assistant Professor of Clinical Pediatrics at the University of Miami in Florida. My specialty is bone marrow transplant and cellular therapy for children with malignant and non-malignant conditions. I also am the PI for gene therapy trial from sponsored trial in children from age 18 to 35. Since the description of sickle cell by James Henrik in 1910, there have been developments in the understanding of the biology of sickle cell disease that has led to a lot of treatments. Interestingly, his first management recommendations were rest, nourishing food, syrup of iodide, and iron. Since 1910, with these recommendations, we are doing a lot more for our patients. At this point, also able to offer them stem cell transplant or gene therapy for cure. So today, we will talk about bone marrow transplant in the context of sickle cell disease. I will present a brief overview of bone marrow transplantation, talk about some of the principles of bone marrow transplant procedure, and we'll show some slides about the technique. Then we will talk about the complications of bone marrow transplantation in general, and a few that are pertinent to sickle cell disease. Sickle cell disease is a group of inherited disorders characterized by mutations in the gene encoding for hemoglobin beta subunits. So this schema shows the DNA sequence of the beta globin unit. You will see that codon 6 glutamic acid shows as the normal sequence. In sickle cell, that is shown by the arrow. In sickle cell disease, the sequence at codon 6 is switched from glutamic acid to valine. This leads to conformational changes in the red blood cell that result in a destruction of the cell under stress. So looking at the pathophysiology of sickle cell disease, I put together this little schema, the little round circles there, the membrane, and under stress, the hemoglobin S undergoes polymerization. This leads to sickling. In addition to the polymerization, there's also activation of inflammatory markers that lead to sickling and some sticking of blood of platelets and other cells. The shear stress of the red blood cells leads to hemolysis. And with all that, with the sickling, sticking of the sickling cells causes vaso-occlusion, which is the hallmark of this disease with the pain and multi-organ dysfunction that we observe. The occlusion continues even when children are between these vaso-occlusive episodes. There's ongoing tissue destruction from ischemia and infarction. This long-term leads to chronic inflammation that feeds back into the vaso-occlusive episode. And these children have an ongoing complex of slow but steady organ dysfunction that leads to their early mortality, poor quality of life. This is the similar schema, but the point I would try to make here is the acute and chronic tissue ischemia that occurs over time leads to end organ damage. That's when we see them with painful vaso-occlusive episodes. Patients come with acute chest syndrome. They develop cerebrovascular disease, leads to moya and strokes. Pulmonary hypertension is common in this group, again, because of the vaso-occlusive episodes. The paroxysm occurs in the male patient. Skin ulcers are common because, again, of the occlusion of the vessels along the skin. Retinopathy is observed in these patients around age 10. It's recommended that they begin routine eye exam. We do that in our center here. And avascular necrosis is also a hallmark of this disease. So this very complex disease that leads to poor quality of life, there have been a lot of developments in trying to modify the disease. We now have agents that block polymerization, but agents also that try to prevent adhesion that will also mitigate vaso-occlusion. We have agents that now are anti-inflammatory, try to calm down the pro-inflammatory state that's ongoing, but none of this leads to cure. The only cure for sickle cell disease now is manipulation of the gene ex vivo by gene therapy or in vivo by stem cell transplant. Bone marrow transplant then is a transfer of healthy hematopoietic stem cells from an asymptomatic donor into a patient that corrects the sickle cell gene defects. I must say that in this regard, a donor who is a sickle cell trait can still be a donor for a patient with SS, because in this situation, we are swapping the AS phenotype for the SS phenotype, which you can see, we all know is a huge difference. The AS, the most likely to live healthy lives, as opposed to SS where they have poor quality of life. This shows the procedure that is done in the operating room. The patients are lay prone. A technique has to be done with experienced anesthesiologist who knows how, who's confident and competent how to sedate this group of patients, because the approach for the harvest is from the posterior superior iliac spine. The trocar, biopsy, a needle, and cannula is inserted around the posterior superior iliac spine on both sides, and multiple passes are introduced to retrieve about 3 to 5 mils of marrow each time. This is delivered to the nurse into the receptacle in the OR, and after that manipulated and filtered and placed in a bag. So the product will look like this at the end of the harvest, based on the patient's weight, and we calculate the dose at midpoint. The sample is sent to the lab, and we have a quick midpoint as to the number of cells that we have. Based on that, we will collect more cells to achieve our goal. Interestingly, the cell collection after the midpoint over time is a bit less than prior. As your harvest continues, you tend to pick up less stem cells. The product is then, after manipulation in the stem cell lab, if it's a bio mismatch, the stem cell team does their processing. And if this patient is in house, the stem cells are infused the same day. If the donor is from another center outside or out of town, the harvest is done the day before, and the product is shipped with a courier, personally delivering the products at the transplant center the next day. It's also good to know that there are other stem cell sources. So this procedure is actually called hematopoietic stem cell transplant because bone marrow was the initial source. In most cases, we tend to call it bone marrow transplant most of the time. But peripheral blood now is a good source of stem cells. These patients, these donors are mobilized with agents that mobilize the stem cells from the marrow niches into the peripheral blood. And the machine, as you see in this picture, this is an old Spectra. We now have new Optia machines that are more efficient. But this Spectra also is a good workhorse that does a good job. So the Spectra is used to retrieve the stem cells peripherally, and then they are processed and used for the stem cell transplant. A cord placenta is also, and the cord also a rich, good source of stem cells, but these are limited by the size of the cell of the cord and the placenta, and therefore your dose is limited. It works well in little children, but as you get older, bigger, then the dose becomes insufficient. With the bone marrow transplant, the hematopoietic stem cell is our graft. This multipotential stem cell is able to differentiate into multiple lineages after it's been infused. So the arrow shows you the stem cells of interest, and the erythrocytes, as you see in the red circle, develops through the lineages, depending on signaling and the transcription factors. And this ends up becoming a red blood cell that is healthy without a sickling. If an AA donor is used. If an AS donor is used, then the process will lead to an AS status. Also note that the hematopoietic stem cell infusion leads to a new repertoire of immune cells and also cells of the myeloid lineage and platelets. The principles of bone marrow transplant, this process begins with selection of a donor. Patient and donor go through an intense workup, including lab blood work, scans of the brain, the chest, the abdomen, the pelvis. That's for the patient to surveil for any latent infection. We look great for mold and other indolent lesions that might flare up when the patients are taken to the immunocompromised status. With a patient, we always want to ensure that the hemoglobin S percentage is less than 30%. In that way, to mitigate any risk of VOs, a vaso-occlusive event during the process. The donor also goes through a workup, detailed medical history, social history, surveillance for any potential infections. And if all that works well, there's no result from the workup that precludes the donor being a donor and the patient going for the transplant, then a date is set for the transplant. Patient is admitted to the transplant floor and began on immunosuppressive medication. This most of the time is chemotherapy, and sometimes with radiation or combination. And based on the regimen that is chosen, on day 0, the stem cells are harvested from the donor. And if it is an out of state, out of town donor, the harvest is done the day before and brought to the treatment site by the courier. The product is infused on the day of the transplant, and after that, supportive care is provided until the stem cells engraft. Typically, 14 days post-infusion for the peripheral stem cells, a little bit later for bone marrow, and the cord blood is they have a delayed engraftment because of the paucity of stem cells and naive and T cells. Nutrition is maintained all throughout. Most children, when they develop mucositis, are unable to eat and will require TPN or the other forms of supplemental nutrition. We have all our patients undergo psychology tests, psychology evaluation to be sure that they understand what they're going through, and to make sure that they also have social support network in place throughout the transplant. So this schema tried to put together a diagram of the events pre-transplant. The Horizontal bar tells the time frame of the transplant. Day -12 is about the time when the patient is admitted, and the 180 beyond is after transplant. Day 0 is the transplant day. So condition begins with chemotherapy or radiation combination, and by day 0, the stem cells are harvested. By day 2, the prophylaxis for GVHD is begun. Oftentimes, cyclosporin is used, or tacrolimus, one or the other, depending on the center, in combination with mycophenolate or methotrexate. And this is to prevent graft-versus-host disease after the stem cell infusion. This is a schema of regimen that we use at our center here. I looked on the clinicaltrials.gov, but on March the 3rd, and there's almost 126 studies right now. Some of them closed, most of them open to accrual for sickle cell disease transplants. This tells you that there's interest in this field, and there's a lot more that is being learned, discovered from the research being done here. The condition regimen contains multiple agents that are used, experienced in different centers. In our center, we use morpholan, tiotropium, and fludarabine, and other centers use busulfan with combination. Tiosulfan is mostly used in Europe. It's not approved in the US yet. Hopefully, it will be approved soon. And the radiation as a combination of with other chemotherapy agents. The intensity of the regimen depends on the dose. And so if a malablative condition is considered, in which case, if the regimen is administered, the marrow will never recover without a rescue of stem cells, as opposed to reduced intensity or non-malablative conditioning, where if the stem cells are not infused, the marrow can recover within 2 to 3 weeks for reduced intensity, and non-malablative conditioning, the marrow never goes into total loss of production. Discussions prior to stem cell transplant should be had in this group. A donor selection is, as we talked about earlier on, the patient has to be aware of toxicity that occurs with the transplant. Organ dysfunction is quite common, most of the time irreversible, in few cases irreversible. Infertility is a concern. All our patients who are of childbearing age are offered fertility evaluation and preservation of the sperm or the egg if interested. There's a risk of secondary malignancy after stem cell transplant. In a sense, any condition that is treated with chemotherapy agents has a risk of developing a secondary malignancy. We ensure that all our patients and their families undergo psychosocial evaluation to make sure that they have good support network and they're ready in a nice frame for the transplant. The mortality from some transplant is not little, and patients must be made aware that there is a risk of mortality at transplant. Transplant tends to be very expensive, and so it's not affordable for many people. In countries where there's not good insurance program, it's out of reach for many of the constituents. It is always good to let the patients know that bone marrow transplant does not correct any pre-existing defects from sickle cell disease. So if they have a history of stroke or with any deficit, the deficit will not be corrected with the stem cell transplant. Although there is some data showing that there's amelioration of any complication, it just doesn't get totally resolved. Donor selection is based on the HLA compatibility match between the donor and the recipient. The major proteins that are evaluated for HLA typing are found in the MHC cluster, which is on the short arm of chromosome 6. Over time, it has been shown that clusters around HLA sites for HLA1, HLA-A, HLA-C, HLA-B, HLA-R, DR, DQ, DP are very significant in determining the engraftment and rejection of transplant. So each of these sites has 2 alleles. So typing is done on each side and looking at the nucleotide sequencing. If the donor and the recipient match at all 10 sites, it is determined that it's a 10 out of 10 full match. If the match is on 5 of the 10 sites, 10 alleles, then it's 5 out of 10. If it is 6 out of 6 sites, then it's 6 out of 10. And age is also considered during the donor selection. The younger age, less than 40, the better. And even the younger, the less than 16, the better. CMV status is also considered. ABO incompatibility is also considered, but these two are not they are not major conditions. If we have ABO major compatibility, we still can use a donor, and the stem cell lab has the protocol to manipulate the products. Gender mismatch from a female multiparous donor to a male recipient can be a cause of increased risk of GVHD because of the allo reactivity that occurs. Donor types can be from a related donor or unrelated, which typically is from the volunteer that are registered in the donor pool. And from the donor registry, the source can be bone marrow, peripheral blood, or umbilical cord. Complications of bone marrow transplants ought to be really looked at before you proceed on a genital transplant, and a lot of preparation has to be put in place to manage these complications or prevent them. Infections are common after transplant because the patients are immunocompromised. Graft-versus-host disease is an entity where the donor cells attack the recipient tissue. The patient can actually reject the graft entirely, and that's graft rejection. The condition regimen and the other medications that are used for the stem cell transplant, in addition to pre-existing conditions in the patient, can result in multiple organ dysfunction during transplant and even organ failure. Sinusoidal obstruction syndrome is a common entity post-transplant in sickle cell disease patients because of the line endothelial damage, vascular damage. The same with posterior reversible encephalopathy syndrome and transplant-associated microangiopathy, which we will all discuss in the next few slides. The beauty of stem cell transplant in sickle cell disease patient is that you do not need a 100% donor chimerism for good outcome. Unlike leukemia, where you need 100% chimerism to ensure that none of the donor cells are around, in sickle cell disease, we can tolerate mixed donor chimerism as long as the donor cells are producing enough red blood cells that don't render the patient symptomatic. So challenges of bone marrow transplant sickle cell disease patient, just as mentioned earlier on, graft failure, graft-versus-host disease, it leads to infections, results in organ dysfunction, mobility, and overall poor quality of life, and mortality is a concern. And so this begs the question about what the ideal regimen for bone marrow transplant in sickle cells should be. You don't want to switch one chronic ailment for another chronic ailment after transplant. So if this is a haplo transplant that we're doing, and it could be any other form of transplant, it could match sibling, it could be also a match unrelated transplant, but in all these situations, you want to minimize the toxic effects, which is graft failure, rejection, GVHD, infections, and organ dysfunction, and maximize the chances of having a disease cure, improved quality of life, and early engraftment. This requires a fine art to try to achieve this, which is the dilemma for a stem cell transplant physician and the group in managing these patients. This article shows that in patients who are less than 16 years of age, they have a better outcome compared to their colleagues who are older than 16 years at transplant. And so the earlier the patients are referred for transplant, the better in centers where transplant is done. And this also, this paper also showed that for any 1 year increment in age, there is a 9% increase in the hazard ratio for treatment failure. And that's all stress the point that when we decide to do transplant, once we have a patient that is eligible, we need to proceed quickly before they develop organ dysfunction. The indications for transplant, therefore, in sickle cell disease are stroke, abnormal MRI, elevated transcranial Doppler, acute chest syndrome with recurrent admissions to hospital, more than 2 vaso-occlusive episodes, requiring admission to hospital, also necrosis, rectal aluminization from transfusions, and other conditions like this, like lung disease, which are not that are not incapacitating. Now, the NIH indications for transplant for patients above age 16 is similar: irreversible end organ damage, stroke, elevated tricuspid regurgitation velocity of 2.6 milliseconds or more, sickle cell renal insufficiency with elevated creatinine or cystatin C, sickle cell liver disease in children also who have iron overload, reversible complications that are managed with hydroxyurea, or patients who have failed hydroxyurea treatment also. So these are the indications for transplant. Because of the complications that can occur with transplant, you want to triage your patient and make sure that they meet criteria before you offer them transplant, or so you're going to offer a child transplant that might end up being more risky than the child's status at that time. Graft versus host disease is the most common complication of transplant that every physician who sees this patient is concerned about. It comes about when the allogeneic stem cells from the donor begin to attack the recipient cells and cause damage. These cells, most of the time, traffic to the liver, the skin, and intestine, but they can traffic to any organ in the body, including the brain. They lead to destruction, as you can see in this schema. On the left, after conditioning, the breakdown of the lining of the gut releases LPS and other antigenic molecules. They are encountered by the macrophage that presents them to the lymphocytes and the cells in the context of the major histocompatibility complex. This leads to activation of the lymphocyte proliferates, and the signaling, they migrate to the donor, the recipient site, like the skin, the intestine, and the liver, where they cause excessive damage. This can lead to early mortality if not managed expectantly. This shows some graphic images of the skin with GVHD, the bully, the blebs. This is stage 4 GVHD, which, if there are other organ systems involved, we shall see the next few slides, can be a high grade that is prognostic for poor outcomes. Risk factors for GVHD include alloreactivity. If there's a mismatch, for any one allele mismatch, there is an increased risk of GVHD for about 10%. Age is also an indicator. The younger the age, the better. the gender mismatch we spoke about, and infections like CMV can trigger GVHD by revving up the alloreactive T cells. So this is a table of the way to evaluate clinical staging of GVHD. On the left, on the first row, you see the staging. Across, you see the tissue involved, and every stage has its corresponding skin, liver, or gut degree of involvement. So with the skin, we look at the body surface area up to 50%. And once you develop generalized erythema and bully, you are in an advanced stage of skin GVHD. The liver is determined by bilirubin level, and the higher than 15 milligrams per deciliter is stage 4 liver GVHD. And the gut is determined by the diarrhea. And as you can see from this slide, any stool, watery diarrhea stool, or more than 1,500 mils a day is stage 4, stage 3 is stage 4 with pain and eye loss. The typo there is not 15,000, it's 1,500 mils, not 15,000. Acute GVHD is then graded after you have the stages. So the stages put together multiple organs and informs you of the grade. The grade is important to take time to do staging and grading because this is prognostic. The staging gives you the stage to develop a grade, which will give you a prognostic evaluation of the outcome, and that determines your treatment plan. So for grade 1 GVHD, you can use topical steroids and emollients. Normally use the mild to moderate potent steroids. For grades 2 to 4 GVHD, you now want to use systemic steroids because you want something that is more efficacious because you have now systemic involvement. You continue with calcium inhibitors if they are already on. Most children at this time will be on tacrolimus, cyclosporin, sirolimus, or a combination of these medications as prophylaxis. And now new agents, including tyrosine kinase inhibitors, have been approved for patients who fail GVHD management with steroids. Another entity that is seen mostly seen in all patients, but it can occur more in sickle cell disease, is posterior reversible encephalopathy syndrome. It's a condition that presents with seizure and is associated with headache and hypertension. The risk of this children is due to the endothelial damage that occurs with sickle cell disease. And in addition to medications like tacrolimus and cyclosporin that is used for GVHD prophylaxis, these medications have been shown to increase the risk of PRES. Patients can be very sick and they can actually be fatal if not expectantly managed. The proposed mechanism for PRES includes vascular endothelial wall dysfunction, ischemia that occur over time because of children who come to transplant already have vasculopathy, and there's sometimes a failure of the autoregulatory mechanism in hypertension. This on my left is a CT scan of a patient with PRES. The arrow denotes areas where there's hypodensity of the image. The PRES is a white matter disorder of the brain. On the right image, you see an MRI showing areas of hypodensity. This is a classic we've seen in MRI pictures of PRES. Sometimes these are not very obvious, but your neuroradiologist will be able to look at other measures and tell you if it is concerning for PRES. Management for PRES, prophylactic medications are key. Most of all our children or patients here begin anticonvulsants prior to transplant. We continue until they're off suppressive medications. And when PRES occurs, prompt treatment of hypertension is key, and escalating the anticonvulsants to abort the seizure. When it occurs on patients who are on immunosuppressive medications. Sometimes you can switch the tacrolimus for CellCept, or for cyclosporine or sirolimus, because you need to continue immunosuppression, or else you're going to trigger GVHD. Sinusoidal obstruction syndrome is another entity that occurs because of the breakdown in the endothelial wall of the vessels. This also occurs a little bit more in sickle cell disease patients because of the pre-existing endothelial damage, vasculopathy. And this typically occurs in patients around from infusion to day 30 post-transplant. There are some reports of delayed sinusoidal obstruction syndrome, but typically most of them will occur by day 30. This entity is previously called varicose disease, and it occurs in about 20% of patients after transplant. It commonly presents with right upper quadrant pain, which is very intense, weight gain, and elevated bilirubin. These children are pretty sick and they're in a lot of pain. And that is also a reason why after transplant, weighing the patient sometimes twice a day as they engraft can clue you into the trend of weight gain before it gets out of control. This condition mostly affects the liver. There's obstruction of the sinusoid leads to congestion of the liver, intense pain as the capsule expands, and can lead to fatality if not managed early. The risk is compounded by chemotherapy agents, and in children with sickle cell disease, elevated ferritin due to iron overload. Studies in patients who have sinusoidal obstruction syndrome, daily CBC and CMP, you want to follow up the bilirubin to make sure that it's not turning up. However, in children, bilirubin has not been shown to be a strong predictor. You can have normal bilirubin and still have sinusoidal obstruction, unlike in adults where the publications have shown that bilirubin is a key finding. Coagulation profile should be followed. Liver ultrasound is recommended in this group. The liver ultrasound is not it doesn't have to be a classic finding. Even though if there's no, the Doppler doesn't show reversal of flow in the hepatic vessels, patient can still have SOS. Management of this patient begin with prophylaxis. All patients must have SOS prophylaxis. We use deoxycholic acid here, and once they are diagnosed with this entity, the defibrotide has been a game changer in managing this patient. All our patients so far that have been diagnosed early have had their condition resolved with defibrotide. This is a medication that has both pro and anticoagulant properties. The etiology of the mechanism of action is clearly not well understood, but seems to be effective in managing these patients. In managing them also, you want to maintain fluid, strict fluid balance. Fluid overload worsens this condition. The transplant-associated microangiopathy also occurs in these patients due to the overlying endothelial damage pre-transplant. The Arthur Young and the group postulated 3-hit hypothesis, meaning that the children already have a pre-existing endothelial damage. During transplant, the condition regimen leads to further destruction of the endothelial wall. And the third hit occurs from medications that we use to support the patient, like tacrolimus or cyclosporine, or infections that will occur with transplant. This leads to a triggering of the cascade, complementary cascade, and hemolysis of red blood cells in the vein. And then that's when you have your thrombotic microangiopathy. This is a schema that's quite busy, but on the left, where you have the red circle, it shows you the complex that initiates this process, platelets and adhesion molecules together form a microthrombi. There is destruction of the red blood cells, just as seen on the film if you use a peripheral smear, and this goes to a cascade of mechanisms. This slide also shows medications that can be used in different pathways to benefit these patients. Infections not typical for sickle cell disease, okay, in all transplants. And this very landmark article published by Dublin and group showed that depending on the phase of transplant, you can predict organisms that are likely to cause an infection and therefore be proactive in your management. So the first phase is the pre-engraftment phase, where there's neutropenia because of the condition you've given, and they break down the barrier. So there's mucositis. Most of them have central venous access. This time, the most common bacteria you see are gram-negatives, which are translocations from the gut. You have gram-positive organisms. So as soon as they have fever, you want to cover them empirically for these organisms. You typically begin with a beta-lactam antibiotic that covers Pseudomonas. And if they continue to have fever, you add gram-positive organism, gram-positive antibiotic. Over time, after the 30, as they go through the second phase of post-engraftment, they now are likely to develop more of gram-positive than gram-negative. And after the 100, encapsulated organisms like strep become, an issue. With the viral agents, herpes simplex virus is most common in the first 30 days. Respiratory enteroviruses do occur, but you see more of HSV. After day 30, you now are likely to encounter cytomegalovirus that continues to the 100 to 1 year post-transplant. After day 100, though, varicella zoster becomes the more likely organism that more likely virus that you will encounter. BK virus also seen after the around the 45, and depending on the population you have of your patient, with HHV6 and BK virus are also common, as commonly seen, but fortunately do not cause as much morbidity as cytomegalovirus does. Well, fungal elements, Candida is seen quite early, Aspergillus much later, around engraftment. Then by the 100, you see more of Aspergillus than Candida species. Pneumocystis should always be in mind. From around day 60, pneumocystis, protein infections can occur, and so these children will have to be on Bactrim or any other agent, the second agent for prophylaxis. This map shows the part of the world where there are increased births for children with sickle cell disease. Clearly, our region, Ghana, Nigeria is well represented there, and that behoves us to continue working hard to be able to manage these patients effectively, and most importantly, work hard to introduce bone marrow transplant in these regions. The last few slides, this is me at Rich Hospital, where we performed the first bone marrow transplant in a child with sickle cell disease. This is a child that was referred to me when she was age 3. No donor was found at that time, and she was on current transfusion. She developed secondary iron overload and alloimmunization, and at age 6 got transplanted with a donor, haplo donor, is now disease-free and doing very, very well. This third slide, this third picture is another patient that underwent transplant in Ghana with sickle cell disease and is doing very well. So in conclusion, gene therapy, including stem cell transplant, is the only cure for sickle cell disease. Bone marrow transplant, however, has toxic complications and should be only considered with the understanding of potential toxicities. Early referral before irreversible organ dysfunction results in better outcomes. So we will recommend that once a child meets criteria, they be referred to a transplant center quickly. Bone marrow transplant can be safely done in low-resource countries, just as has been demonstrated with the program in Ghana and with the work done in Nigeria and other countries in the West Africa region. Thank you all for listening. Have a good day. Bye.